Good morning, ladies and gentlemen. The topic of today's lecture is calcification of skin and subcutaneous tissue. In this lecture, we are going to discuss two different forms of calcification. The dystrophic calcification and metastatic calcification. Dystrophic calcification and metastatic calcification are differentiated in this way that there is abnormality in calcium homeostasis in metastatic calcification. And the calcium is deposited on different part of the body, including skin, because of this defect in calcium homeostasis. On the other hand, in dystrophic calcification, there is no abnormality in calcium or phosphate homeostasis. And the calcium is deposited primarily in inflamed or damaged tissue. So first, we are going to discuss the various different kinds of dystrophic calcification, which is usually secondary to some inflammatory condition or some infection. Inflammation, most often seen as a predisposing cause of dystrophic calcification, are the autoimmune diseases. And among the autoimmune diseases, the most important are dermatomyositis, localized scleroderma or the CREST syndrome, systemic sclerosis, and in some variants of lupus erythematosus, particularly lupus paniculitis. Among the infections, the most common are the two parasitic infections, onchocerciasis and cysticercosis. Epidemiology. Cutaneous calcification is seen in 30% of adults with dermatomyositis and 70% of children with dermatomyositis. Associated calcinosis is more often seen in women than men with a ratio of 4:1. There is no other particular predisposition. In addition to the autoimmune diseases, other rare association of cutaneous calcification are porphyria cutaneotarda, morphea, and lichen sclerosis. I mentioned about the infections. Pathology. The characteristic histopathological appearance is that of calcium deposits, which are seen as blue color, irregularly shaped globules seen in the dermis. If the deposits are in subcutaneous tissue, they are in a form of irregular masses. On H&E, they look blue, and on special stain of calcium, that is von Cosa stain, all these calcium deposits turn black. A mild to moderate chronic lymphohistiocytic infiltrate surround these calcium deposits. Another features of all kind of dystrophic calcification is the transepidermal elimination of calcium, particularly seen in dermatomyositis and in CREST syndrome. In pancreatic paniculitis, there is fat necrosis with ghost cells, and there are foci of calcification as well in the cytoplasm of the lipocytes. You can see this, the few deposits of calcium are small granules, while there are large deposits as well. The cutaneous calcification present for many years after the onset, of the underlying disease. And this is reported to be up to 10 years in scleroderma and adult dermatomyositis, but it is short onset after 2 to 3 years in childhood dermatomyositis. In dermatomyositis, calcification mainly develop on trunk and limbs in both childhood and adult form. Yellow-white nodules and plaques frequently ulcerate, discharging a chalky material. This is transepidermal elimination. And sometimes this calcification is more universally distributed on the body, and this is called as the calcinosis universalis. Then calcification may develop in the underlying muscles, which results in contracture and deformity. This picture shows calcified nodules on the anterior aspect of thigh and leg. And on radiology, you can see these calcium deposits all are seen in the subcutaneous tissue. Calcinosis is a part of definition of CREST syndrome, where C signifies calcinosis. And these nodules are usually present on elbows, knuckle, and volar aspects of the finger, particularly sites of trauma. Cutaneous calcification is described in Porphyria cutanea tarda, especially when it is associated with pseudoscleroderma. Here again, you see this perforation where the ulcerated plaques extrude the chalky material. And they heal with scarring and on scalp lead to permanent alopecia. Dystrophic calcification seen on the volar aspect of the fingers in patients of CREST syndrome. In systemic sclerosis, large calcium deposits are seen on the palmar skin, which is highlighted on X-ray soft tissue. Rarely, calcification is seen as a complication of SLE, particularly in the nodules that develop in subcutaneous tissue or buttock. And it is also seen in lupus paniculitis and occasionally in DLE. Sometimes calcification is also seen in mixed connective tissue disease in polymyositis and rheumatoid arthritis. Occasionally, calcification is also a complication of chronic leg ulcer, irrespective of cause, which may impair its healing. Erythematous, well-defined nodules and plaque on cheek, back, and buttocks is seen in subcutaneous fat necrosis of the newborn, which resolves spontaneously but may calcify and is associated with hypercalcemia. This cause is unknown. As far as the infections is concerned, rare causes are onchocerciasis and cysticercosis, which may cause calcified nodules on head, pelvis, and pectoral area. There is one report of cutaneous calcification due to intrauterine herpetic infection. Then clinical features. Complications and comorbidities. Ulceration with secondary infection is the main complication of cutaneous and subcutaneous infections. When widespread, that is in calcinosis universalis, contracture and deformity may also occur. Disease course and prognosis. If untreated, calcification rarely regress. Then investigation include the serological assessment for connective tissue by ordering anti-nuclear antibody, double-stranded antibody, and ANCA, and extractable nuclear antigen. Then full biochemical investigations like serum calcium, serum phosphate level is important. And in addition, alkaline phosphatase, vitamin D level, and parathormone level is also done. X-ray on particular sites and skin biopsy may be helpful in confirming the diagnosis. The X-ray is many a time helpful in picking up the calcified deposits. First line treatment of calcification include surgical excision, wound debridement by CO2 laser. Then localized areas, intralesional steroid is given, usually in a dose of 20 milligram per ml every 4 to 8 weeks. Sodium thiosulfate is given both in a topical solution, 10% twice a week, or intrarenal injection, 0.1 ml of 25% solution. Second line treatment, mainly given for extensive disease, diltiazem up to 480 mg, biphosphonates, aluminum hydroxide, and minocycline 200 milligram per day. Then comes the third line treatment. They include colchicine, ceftriaxone, probenecid, warfarin, and intravenous immunoglobulin. Surgical excision of localized disease is the most appropriate choice. In addition to CO2 ablative laser, extracorporeal shock wave lithotripsy is also one of the treatment modalities. Then a few words about the dystrophic calcification due to different causes. It can develop as a result of trauma or infusion of calcium-containing materials. Calcinosis develop at site of trauma, resulting in cell death, releasing alkaline phosphatase, creating an increase in intracellular calcium, and an alteration of localized pH result in precipitation of calcium. Then leakage of infusion containing calcium salts like heparin or low molecular weight heparin again cause inflammation, cell death, and calcification. Collagen appeared to play an important role in the process triggering this mineralization. Epidemiology. Calcinosis from calcium-containing heparin injection is more commonly seen in renal patients with abnormal calcium homeostasis. Then history of trauma is usually evident. Heel prick calcinosis is reported after multiple heel pricks carried out in neonatal period, although it may develop after even a single heel prick. It presents as firm papule on the heel, which becomes symptomatic if persists until the infant starts to wear shoes. These are the heel prick calcinosis. Usually, the calcification due to trauma or infusion result in warm tender swelling at the site of injection within days or weeks after the injury or infusion. Ulceration and necrosis may also develop. Calcification also develop at the site of electroencephalography by use of calcium electrodes paste. This is a picture of calcinosis induced by post-heparin infusion. Investigation. It's probably sensible to exclude systemic causes of calcinosis by checking serum calcium phosphate, alkaline phosphatase, and vitamin D and PTH. Then X-ray and skin biopsy is done to confirm. Management is mainly conservative with local wound care and care of ulceration. If lesion persists, then it may be excised. Heel prick calcinosis usually resolve without treatment, although for persistent lesion, excision is required. Infusion injection calcinosis tend to resolve once heparin is stopped, although sometimes surgical excision is again required. Dystrophic calcification is also seen in certain tumors and in genetic conditions. And the tumors may be benign or malignant. And the most noticeable is pilometricoma, which is seen in almost 75% of pilometricomas. Other lesions which get calcified include BCC, epidermoid cyst, vascular and melanocytic lesions. Calcification is also seen in certain genetic conditions, like in Ehlers-Danlos syndrome, which is a disorder of collagen, pseudoxanthoma elasticum, which is a disorder of elastin, and various aging, premature aging syndrome, like Werner syndrome and Rothman-Thompson syndrome. The calcification and ossification of tumors is often asymptomatic and only noticed once it is removed for histopathological examination. In addition to pilometricoma, other which presents as mobile hard subcutaneous papule or nodule due to calcification, other hair follicle tumors that may calcify include pilar cyst, and calcification is also seen in epidermoid cyst. Perforation of the calcium deposits may also be seen in all these conditions. Melanocytic nevus, particularly the intradermal melanocytic nevi, occasionally calcify, and so does the BCC, pyogenic granuloma, neurilymomas, seborrheic keratosis, atypical fibroxanthoma, and several melanomas. Excision of localized area of calcification or calcified tumor is the only useful treatment. Then some idiopathic condition may also result in dystrophic calcification. One of this is idiopathic scrotal calcinosis, where subepidermal calcified nodules or tumors is seen. Then miliary calcinosis cutis is another kind of idiopathic condition. Localized calcinosis of vulva, penis, breast, and other areas are also well described. Many of these cases represent dystrophic calcinosis. The dystrophic calcinosis is self-evident, and scrotal calcinosis, as obvious, is seen exclusively in male. Tumoral calcinosis is seen twice as common in female, and it is more seen in Africa. Scrotal calcinosis present as white subcutaneous firm nodules, which are usually multiple. Subepidermal calcified nodules frequently seen in childhood on head and extremities, solitary hard yellow-white papular nodules up to 1 centimeter in diameter. The tumoral calcinosis or calcification in tumors present as large subcutaneous masses around major joints and most often seen in adolescent. Miliary calcinosis is a rare form of calcification seen most commonly in children with Down syndrome. Then idiopathic calcinosis universalis is described, although some of the cases represent amyotropic dermatomyositis. Here is a little correction. The tumoral calcinosis is an inherited condition that causes high level of phosphate in the blood. And these high phosphate levels results in large calcium deposits in the subcutaneous tissue in the major joints and is particularly seen in adolescents. This is a picture of this is a picture of scrotal calcinosis. Biopsy and radiology are both used to confirm the diagnosis. And in extensive disease, serum calcium and phosphate level and other biochemical profiles are also done to exclude the systemic causes. Excision is the treatment of choice wherever applicable. Spontaneous resolution may occur in miliary calcinosis. Then we have come to metastatic calcification. As described in the early part of the lecture, cutaneous metastatic calcification is due to deposition of calcium salts in the skin resulting from abnormal systemic calcium homeostasis. Cutaneous involvement results most commonly in nodular calcification in periarticular distribution. So one of the presentation of metastatic calcification is nodular calcification periarticular. And the incidence and prevalence of metastatic calcification is unknown and can present at any age. Associated conditions for metastatic calcification: hyperparathyroidism, hypervitaminosis D, milk alkali syndrome, sarcoidosis, bone metastasis, hyperphosphatemia, and vitamin D deficiency. Pathophysiology. In metastatic calcification, the precipitation of calcium in tissue results from high circulating level of calcium or phosphate. And on histopathology, deposit of calcium appear similarly as in dystrophic calcification. They appear blue on H&E and black on von Cosen, both in dermis and subcutaneous, surrounded by inflammatory infiltrate. Usually, the lesions of metastatic calcification are asymptomatic. Mainly, they are deposited periarticular. In addition, other signs of hypercalcemia are seen, and these signs of hypercalcemia include abdominal pain, renal failure, cardiac arrhythmia, and depression. Extensive miliary calcification is also reported in hyperparathyroidism resulting from renal failure. And renal impairment is the main complication of metastatic calcification. The metastatic calcification generally resolves once the underlying cause of hypercalcemia and hyperphosphatemia is corrected. These are gross deposits of calcium in metastatic calcinosis. Full biochemical workup is required so as to detect any underlying malignancy. Radiology and biopsy may also be done to confirm the diagnosis. First and foremost is correction of hypercalcemia and hyperphosphatemia. Then surgical correction or removal of the calcium deposits may be required. Now we are going to discuss an important condition which is called as calciphylaxis, also known as the calcific uremic arteriolopathy. Calciphylaxis is serious, life-threatening, thrombo-occlusive vasculopathy most commonly seen in setting of renal failure. It is characterized by calcium deposition in skin and in subcutaneous tissue, both within vessels and in the surrounding tissue. The pathophysiology of this condition is poorly understood, and there is no universally accepted treatment. Death usually results from sepsis or systemic thrombosis. Incidence and prevalence. Calciphylaxis is estimated to have an incidence of 4.5 per million. The prevalence in chronic renal failure is reported to be approximately 1%, and in hemodialysis, 4%. Majority of patients with calciphylaxis are middle-aged or elderly, although it is reported in infants as young as 6 months. Female predominance to male is 4:1. Epidemiology. The associated diseases or the diseases which are associated with calciphylaxis include renal failure, hyperparathyroidism, hepatic failure, and malignancy. Other risk factors include obesity, warfarin use, corticosteroid use, diabetes, connective tissue diseases, and protein C and S deficiency. Pathophysiology. It is likely that the pathophysiology of this condition is multifactorial. There are abnormalities of calcium homeostasis, which is common but not invariable. Coagulation abnormalities are also recorded. Again, it is not consistent. Parathyroid hormone, corticosteroids, aluminum, liver disease, and various forms of inflammation activate final common pathway which have a role in calciphylaxis. A potential role of warfarin can be explained by inhibition of vitamin K-dependent gamma carboxylation of matrix GLA protein, which inhibit the extraosseous calcification. So once this protein is inhibited, then calcification is promoted. Pathology. The medial calcification, intimal fibroplasia, and thrombosis of panicular arteries with cutaneous necrosis is seen. Extravasation of calcium deposits is variable. Here in this picture, you can appreciate that the calcium deposits are seen on the wall of medium-sized vessels. Such deposits are also seen in the subcutaneous fat or in the dermis. Usually, the typical presentation is with purpura, then ulcerating, necrotic plaque on lower abdomen and thigh. The severity of pain is often disproportionate to the clinical appearance, so it's quite painful and is the first sign of disease progression. On lower leg, Calcification may be less obvious clinically, but libido is characteristic. In some cases, there is more diffuse subcutaneous calcification, which is somehow have a better prognosis. Calciphylaxis is reported on penis, breast, tongue, and other internal organs. Ulceration are usually irregular, stellate, or deep. Surrounding libido is evident of local vascular thrombosis. You can see this initial libido, then this necrotic areas, then large ulceration. This is a progressive calciphylaxis. Differential diagnosis, other causes of cutaneous calcification may be considered, and calciphylaxis may be mistaken for vasculitis or PG, pyoderma gangrenosum. Warfarin and heparin necrosis may be a cause, may look similar. Hypertensive ulcer of Martorell is another differential. In more severe form, the necrotizing fasciitis may be considered as a differential, but it is more rapidly progressive. Disease course and prognosis. The metastatic calcification generally resolve once the underlying hypercalcemia or hyperphosphatemia is corrected. Classification of severity. It is difficult to predict which case of calciphylaxis will have a better outcome. And it is suggested that those patients with more obvious subcutaneous calcification without libido or necrosis have a better course. Complications and comorbidities. Renal impairment and features of systemic metastatic calcification. The principal complication of calciphylaxis is septicemia, and internal organ involvement is rare. Disease course and prognosis. The rate of progression of calciphylaxis is variable, but secondary sepsis is common. Although calcification of cardiac, GI tract, and other systemic arteries may be demonstrated, an ischemic process similar to skin is usually not seen internally. The mortality is high, up to 80%, and median survival is less than 3 months. Even in those cases where treatment seems to improve the cutaneous feature, mortality is still more than 60%. Investigation, full biochemical workup. Trauma may aggravate calciphylaxis, and so the clinical diagnosis should be made without a biopsy. However, in a clinical practice, there is a need of definite histology in such a serious condition, especially when the diagnosis is not very obvious. Then a single deep biopsy of indurated plaque is needed to demonstrate the subcutaneous calcification and involvement of vessels. In addition to assessment of systemic calcium homeostasis, level of glucose and HbA1c, liver function test, and coagulation screening must also be checked. Then for secondary septicemia, it is must to take the samples of blood, tissue swabs for culture. Management. There is no universally accepted treatment regimen for calciphylaxis. Most promising treatment is intravenous sodium thiosulfate. This certainly does not seem to improve symptoms quickly, and the short-term outcome appear to be better. Long-term oral sodium thiosulfate is reported to be effective. Correction of calcium homeostasis is sensible, but may not affect the outcome. Several case reports in literature with successful treatment with sinasulfate, which is a calcimimetic agent that reduces parathyroid hormone level and phosphate binder, and another treatment is phosphate binder sevelamer. Other management strategies would include parathyroidectomy, which is of questionable benefit and should be reserved for refractory hyperparathyroidism. Local debridement is shown to improve survival. Anticoagulation is logical but controversial. And it is important to exclude warfarin or heparin necrosis before you recommend this. So this brings to the end of this talk. And I hope to see you next time with another edition of my lecture. Till then, it's goodbye and have a good day.